Hello. In this short video, I want to introduce some strategies for effective health education and promotion. Again, my name is Cougar Hall, and I'm a professor at Brigham Young University. My background is indeed in health education. Happy to share just a couple of thoughts with you. This video shouldn't be too long. Here we go. This is number one of 10 strategies that are provided by the Centers for Disease Control and Prevention, specifically for health education and health promotion efforts. And the first makes a lot of sense. It says we need to focus on clear goals and related behavioral outcomes. So as we do some program planning, we need to really be specific. What is it that we're trying to accomplish? And here's the way I've worded this: establish specific, desired, and measurable outcomes. Now, my team has put together resources that should help you related to water and sanitation and hygiene. So we might think, what are those specific behaviors that we care about the most and that we can measure? It might have something to do with rates of breastfeeding or duration of breastfeeding. It may have something to do with hand washing or food preparation. But these are things that we can really be really specific. This is what we're trying to accomplish. And if we are successful or effective with this particular program, these will be the outcomes. The second one that CDC gives us says we need to plan and implement only research-based and theory-driven interventions. This is really important. We don't need to reinvent the wheel. In fact, we should not reinvent the wheel. Many programs have been out there, many successful, many not so much. We need to review the research literature, make sure we're drawing those most important components or pieces from previous work and previous efforts. And certainly, as you've had a chance to review what Dr. West prepared, his team really looked at theory. And Dr. West is an expert in behavior change theory. And he presented the most prominent theories related to health behavior change. What I would say from a health education perspective is we may or may not implement every construct in those theories. We may pick and choose those things that most likely are going to fit into our program. Certainly, we'll likely have something related to self-efficacy. We might have something related to observational learning or vicarious learning. I think social support is something that we see across almost every behavior change theory. So allowing others the opportunity to learn from and interact with those people that they look up to, that they might model, going to be very important. So the way I've worded this here, just to be real concise, we should apply theoretical models or constructs from theories known to help modify health behavior. I'll come back to this later in this presentation, but we really don't care so much about the amount of knowledge that participants gain in our programs or in our studies. What we're really hoping for is behavior change. We want to see them move the needle as far as their behaviors. And these theories and basing our programs on the existing literature is going to give us the best chance for that type of success. Number three, as far as our effective strategies, says that we need to address values and attitudes and beliefs, both of individuals and groups. So public health is really focused on population behavior change. Now, we certainly are going to work on an individual level, but there are significant benefits and efficiencies from working at the population level, especially related to prevention of health challenges. So we need to make sure that we're taking into account, cultural norms and what individual groups believe and what they consider to be important. So in so much as we can understand how these groups and individuals see the world and what they value and what they consider to be important or not important, that gives us a baseline for how we can move forward. And we can use knowledge and we can use information. We might even use statistics and relevant data to try to shift those norms. We don't have to have huge shifts in most cases. We want to be, we need to be responsive to where they're at, but how can we move them along by shaping their attitudes and their beliefs? In particular, we want to help people adopt beliefs that are consistent with those values and attitudes related to adopting and changing specific behaviors. So related to WASH, as my team has been focused on, we can shape attitudes related to breastfeeding, related to hand washing, related to the self-disposal, the proper disposal of human waste. Those things are going to be really key to the success of our education efforts. I tried to make this real concise. I said here, programs should be culturally appropriate and build on those individual and group values. For number 4, we're going to always try to address social pressures and influences. There are a great many social pressures. Some have to do with how a specific community or culture, how they value women and see women and girls' roles. So many of these pressures are related to religion or just, cultural beliefs that have been adopted and been reinforced and supported over time. In many cases, social pressures come from friends and family, but also they might come from media. And in so much as social media is having a tremendous influence now, those are things that we need to take into account as we do our program planning and as we get our message out there. I've tried to make this concise as well. I've summed this up by saying all behaviors and practices are influenced by a variety of social pressures and influences. Programming must address these pressures. Again, if we're going to move the needle, if you look at the exposure that our participants or that our target population are going to have with our particular program, whether we're using media or whether we're have some type of interpersonal communication at every single level, even if we have the very best program, individuals are still going to have much more pressure coming from their environment. And so how do we address those issues so that the program is not a wash and that we really can have the influence that we're desiring to have? It's a real challenge in health education, health promotion. When we recognize how many minutes or hours a day individuals and groups are influenced by their environment or by their friends, their family, by media, we recognize that we have a great challenge. But we can do this. We need to just make sure that we're addressing those pressures and helping people both deal with and overcome those pressures, still make healthy choices despite some of those pressures and in lieu of those pressures. Next, CDC recommends that we focus on building personal competence, social competence, and self-efficacy by addressing skills and by skill building, by increasing an individual's self-efficacy and confidence that they can do the things that they need to do to reach the health outcomes that we've established. I'm going to actually create a separate video for this. I don't want to talk too much about it right now, but understand that if we don't help individuals build skills and put more tools in their tool belt, I like to say, so that they have the resources that they need to accomplish what we're asking them to do. Again, whether that be breastfeeding or whether that be hand washing or safe food preparation or disposal of human waste, we need to give them the skills and allow them to practice those skills. If we don't do this, then our health promotion efforts are very likely to simply create anxiety and maybe even shame and guilt because, they've asked me to do A, B, C, and D, but I don't know how to do those things. So skill development, skill building are essential to the success of our programs. And again, I'm going to create another short video because I believe this is so crucial to our programs. And I'll talk about each of these 5 steps in that video. Next, CDC has told us that we need to provide functional health knowledge, and that knowledge should be basic, it should absolutely be accurate, and it should directly contribute to health promoting decisions and behaviors. This is a real challenge because as public health professionals, we think that everything's important. And so we have a difficult time distinguishing between all of this knowledge and all of this information that's out there related to these particular health behaviors. But what do people really need to know in order to adopt these healthy behaviors, in order to engage in healthy behaviors? It's unlikely they need to know everything. So I've tried to be concise on this one as well. And I want you to distinguish between what what's nice to know, what maybe a public health professional might want to know and that amount of knowledge that they might pursue in their own study and their own reading, and what the target population actually needs to know. So I've said here, knowledge is important, yet it's often only weakly associated with behavior. Just knowing something doesn't always lead to that behavior change. So while we need to provide knowledge, we certainly need to distinguish between what's nice to know. There's a lot of gee whiz type information out there. If we can distinguish between that and what people need to know, that's what we refer to as functional health knowledge. It's that amount of knowledge, just those few tidbits maybe, that really are effective in shaping those attitudes and those values and those beliefs that will really propel the individual or the family or the group or the community to adopt new and healthy strategies, new and healthy behaviors. So focusing on functional content knowledge. Knowledge is important, but so often we overdo the knowledge and we overwhelm individuals. Just give them what they need to know to engage in healthy behaviors. Okay, I need to talk less, don't I? CDC suggests that we use strategies designed to personalize information and engage individuals. Our health education and promotion efforts should always be engaging. They should increase the interest and the natural curiosity of individuals and groups and communities. But at some point, we also need to personalize information. If we simply talk globally about the importance of hand washing, about the importance of breastfeeding, then we're going to miss the mark. We need to have individuals really tap down and think, okay, how is hand washing going to change my life? How is it going to impact my children? How will breastfeeding impact me and my children and their health? And what are the things that will help me on a very personalized level? For example, I think it's tempting for us to share information on a global scale about things like diarrheal disease, the rates, the morbidity, the mortality of diarrheal disease on a global scale, maybe even within a nation or a country. So we might be tempted to say, look at how many individuals become sick and the number of children who are stunted because of diarrheal disease in Nepal. But most important is we need to help an individual and a family really contemplate, how would diarrheal disease impact me? How will it influence my life? That's going to be the most important thing. Certainly rates and statistics on a national level are really important, but we have to get someone to really personalize the message that we're sharing. Once they personalize it, we're much more likely to get traction and see behavior change. I've tried to sum this up by saying this: personalization requires individuals to make the leap from recognizing that a certain behavior is harmful to recognizing how that behavior would impact their own life, health, their own dreams, their own goals, and certainly their future, the future of their family and of their children. This is really important, again. Okay, CDC recommends that we provide adequate time for instruction and learning. Sometimes as health educators and public health professionals, we think that, oh, we've got the message out there, we reached our target audience, and they heard our message, and now we can sit back and things are going to just work themselves out. We need to understand it's going to take many efforts, but also individuals and families and communities, they need to hear a message many times and in slightly different ways. So we'll be effective perhaps with a radio message or with something on the television for a public service announcement there. But we need to work at every level to make sure that individuals are getting this message from their faith-based institutions and in their schools and at the community level, and when they interact with their healthcare professionals and when they interact with friends and family. So making sure that we have enough exposure is going to be really important. Making sure that that our programs are sufficient in length and duration. I've tried to sum this up by saying dose and duration of exposure are really key. They're fundamental to adopting new health behaviors and extinguishing existing less healthful behaviors. So understand we're not going to be effective with a one-off approach, with one announcement, with one class. We need to be really consistent and recognize that, boy, we need a sustained public health effort if we're really going to impact change. This next strategy is very, very similar, if I might add. CDC says we need to provide opportunities to reinforce skills, to reinforce positive health behaviors. It may be that we need some booster sessions, so to speak. If you have a community health worker visit a family one time, even though that message and the skills that are taught might be incredibly effective, there's going to be some decay over time. And so we need to make sure that we have a follow-up visit and then a follow-up visit to that, so that, again, there's opportunities to reinforce those skills. What this provides a health educator is an opportunity to troubleshoot and to problem solve. As we return to a community or we return to a home, we can say, okay, what worked and in what ways have we moved forward? And in what ways are we backsliding? Or, oh, we've identified a couple of challenges. We would love to do what you told us to do last time, but it turns out that we have these particular obstacles and barriers. Now we can actually target and look at those barriers and say, how do we overcome those? How do we navigate with the resources that we have? How can we navigate this situation and find solutions to those particular obstacles? That's why booster sessions and follow-up are so crucial for what we're trying to accomplish. I've summarized this point by saying effective programs plan for follow-up and booster programming in providing essential feedback and opportunities for problem solving. CDC recommends that we provide opportunities to make positive connections with influential others. It's so important that the families and the communities that we're working with, that they have an opportunity to communicate with each other. Dr. Ben Crookston has introduced the concept of positive deviance. I think this is a really good example of this principle, is allowing community members to look at each other and to communicate with one another and say, so you have similar resources, you have similar barriers and obstacles. How are you navigating those? How are you getting around those? In so much as we want individuals to communicate with not just neighbors and not just family and friends, we want them to really have significant opportunities to communicate with community health workers, with physicians and nurses at clinics. I think as much as this opportunity to interact with others can be with those that share similar beliefs, similar heritage and background, it's important for an individual to see themselves a little bit in the person that they're communicating with. So as Dr. West introduced the theory of planned behavior, or the theory of reasoned action, he talked about subjective norms. And that is those individuals who I can see myself in, who I look up to, who I respect, who I can connect with. What is it that they want me to do? So much of what he taught in that principle, in that construct, is evident in this particular characteristic. We want individuals to really have the opportunity to interact and connect with those who are promoting health behaviors, who are encouraging health behavior change. It may be that if we're targeting breastfeeding, that we might not only target a young mother. We might also target a husband, a friend. We might target her parents, those individuals that she looks up to, people that she actually values the opinion of. And if we can get those people to understand, here's how breastfeeding will bless your daughter, will bless your wife, will bless your neighbor, your friend, that can actually really help that young mother adopt that health behavior and say, you know what, breastfeeding isn't easy, but the people that I care about and that I look up to, they think it's really important. So I've tried to summarize this as concisely as I could. Social support is essential for health behavior change. Programming should provide many opportunities to learn from and support others. those are our 10 essential and effective strategies for health education and health promotion. If I could review them very quickly with you, we need to have clear goals and behavioral outcomes. We need to make sure that our programs and our programming are all research-based and that they're driven by health behavior change theory. We always want to make sure that we can address an individual or a community. We can address their values and their beliefs. We recognize that every community has certain, there's a certain shared knowledge, and we need to address those values and those beliefs and work within their cultural norms as much as possible. We need to recognize that there are many social pressures, and as I said before, we are going to address those pressures. We're going to try to work with them and address the influence that family and that media and that religion and that all these different factors have. And within those pressures, we're going to make sure that our programming can still be effective. I'm going to focus more on skills. I think that might be the most important thing that is occasionally missing in our health promotion efforts. So I'm going to have a separate video for that. We want to focus on the functional content knowledge. Again, that's the need to know. It's not the nice to know. They don't need to know everything about micro and macronutrients. We can focus on what do they actually need to know and what can they do moving forward, given their specific situations and restraints. We want to make sure that we personalize the message, that it's engaging, that rather than just thinking, oh, this is a global issue that affects everyone, it's how does this particular issue affect me? And how will behavior change in this area specifically bless my life? What would this look like for me moving forward? My dreams, my goals, my family. Make sure that we have adequate time. We recognize that for many people, they've spent an entire lifetime developing and adopting certain behaviors, and to change or alter those behaviors in just, one short effort, a one-day class or one public service announcement or one interaction with a community health worker is certainly going to be insufficient. We also need to provide, related to adequate time, we need to provide opportunities to reinforce skills. We need booster sessions. We don't often really make lasting change with a very short or temporary quick effort. And certainly we need to allow for individuals and communities to interact with others who have adopted healthy behaviors. So this is where positive deviance comes in, and this is when the subjective norm becomes important. Find out, who do these people look up to? And man, can we have those individuals help share our message? As we're talking now about your team in Nepal, it's far more important that in the communities you're working with, that they hear the message from their community leaders than from someone like me, half a world away. And maybe even from someone like yourself, who is still kind of an other, who's someone who's come into the community to share a message. We would much rather have someone within a particular community share the message with their own people. So that there's a lot wrapped up in number 10 as far as how we really are going to influence attitudes and beliefs and help people adopt healthy behaviors. We need to look at who is it that they value and who is it that they look up to, and can we have those individuals share the message? I'm so thankful for this opportunity. I hope that this has been helpful and will be helpful moving forward. Thank you so much.